Tēnā koutou katoa. My name's Samantha. I'm a GP from Hawke's Bay, and I'm really honoured and a little bit humbled to be starting off today. So I'm going to be talking about perimenopause, which I could probably spend about 4 hours doing, but I've tried to condense it to 15 to 20 minutes. So I've just started off being an honorary lecturer at the University of Auckland, and I set up a private GP clinic in Hawke's Bay to improve access to women's healthcare a few years ago. So why this topic? Well, actually, I think as a GP, the more I understand about it, the easier it makes my consultations, and the more I feel I develop my relationship with my patients and that they feel validated. A bit of a transition in my communication was understanding the science and communicating this to help empower women understand what they're experiencing. I'm going to do a bit of a bias about why we should think of HRT, because I think it's probably not on many individuals' radars, and some tips about what to do in 15 minutes. So women live on average 4 years longer than men, but we live in poorer health, and this disparity often starts to increase at menopause. So I think there's definitely an association with hormonal health. Along with this experience, women take longer and present differently to men with their diagnoses and disease presentation. And I think understanding what hormones are doing to the body can actually improve that. So our hormonal journey, we're journeying along with our patients, and so we know these stages. This is based on the Straw guidelines, and they looked at defining the hormonal stages based on the menstrual cycle. They said that in the late reproductive stages, periods may change subtly, and then in the perimenopause, cycle length starts to change, initially by 7 days, and at the end of the stage by greater than 60 days. So these straw stagings and the diagnosis of perimenopause, according to this, is actually just based on menstrual bleeding. But there's more and more information and actually retrospective review of data coming out that it's not just about the bleed. The perimenopause does end 1 year after the final menstrual period, so menopause is actually just 1 day, and we spend 2 to 3, a third to a half of our life in menopause. So yes, this can be a time of diagnostic uncertainty, but one of the things I want to do is to encourage people to feel safe about considering the hormonal impact and still holding tight with what your red flags are and what you want to be aware of when supporting and walking through things with the patient. And also, I tend to describe the science when the patients come in saying, I need bloods to check my hormones, and say, is it all right if I do some explanations first and then we can see what you think would be best for you? So as per the previous slides, average duration 4 years. So mid-40s and even early or late 30s, symptoms can start to change. It's often termed as the second puberty. We know what puberty is. We're kind to our adolescents. Should we be kinder to our midlife women? So this is kind of just a bit of a slide to say it's really multifactorial. Midlife is hard. Society can be challenging when we're supposed to be busy all the time. Any form of 15 minutes or just medication is not really going to cut it. But I think this I often use this as an infographic to support women that we're not going to be able to solve everything immediately. So back to the science. In a nutshell, the brain releases FSH. FSH stimulates the ovary to release estrogen. What does estrogen do? It thickens the endometrial lining. We ovulate. Estrogen drops. Estrogen then increases again in the luteal phase. And at this point, progesterone rises as well. The endometrial role of progesterone is to stabilize the endometrium. So I often show this slide in consultations to be like, this is why no day is the same. This is why we feel different every day. So then what happens at perimenopause? So for me, understanding this was a bit of a game changer. And I say to my patients, okay, so at perimenopause, the ovary is getting a little bit tired, needs a little bit of more of a wake up. So the FSH rises. And we don't know what it's going to rise to. And eventually, the ovary wakes up and it kind of says, I can do this, last ditch kind of attempt kind of thing, and it surges. So estrogen levels go higher than in the reproductive years and actually even at puberty. And then what goes up must come down. Hence, 2 really big peaks every month. So every 2 weeks, it's understandable then to feel different. And you can see here on this graph that, once again, I use this a lot, that the peaks at perimenopause are higher than at puberty, and often that's really validating. And think about a lot of midlife women have teenage children too. And then at menopause, we know what happens. FSH rises and estradiol drops. So I love this slide. I've now got it printed up on my wall, but I think it really demonstrates why so many symptoms occur and why actually we don't need to go through all of them, but if we explain it, then it can be really validating. I haven't talked about progesterone much, but because estrogen's known as the main hormone that drives menopause, but actually progesterone has a role too. Progesterone levels decrease from ovulation and, decrease from mid-reproductive stage. So actually, what does this mean? Well, it's really common in the media, and women frequently say, I'm estrogen dominant, can you manage it? And I have a low progesterone, so I'm using progesterone cream. And to me, then I've explained this, and often women understand where I'm coming from evidence-based research, and I think that helps the relationship. So we know common symptoms, hot flushes, that's what the previous guideline said would be the indication to prescribe hormone therapy. I'm actually going to talk predominantly about mood changes and actually challenge why women shouldn't just be called the old hag, and it's actually not really fair that men are kind of known as they age as the silver fox. So hormones, symptoms change throughout the perimenopause and menopause transition, and as you can see in perimenopause, predominantly it's psychological symptoms. And here, this slide is basically just to demonstrate how the symptoms of menopause are really, really vast. Hormones flatline, and that also therefore makes sense as why women too tend to feel better in the menopause because they haven't got these surging hormonal changes. They adjust over time to the low levels of estrogen. And once again, validating the human brain and physiology that female brains are really good at rewiring and adapting to change, actually better than male brains. So, putting this all together, well, actually, what does it mean? So, often, perimenopause symptoms present with worsening premenstrual syndrome. And a lot of these symptoms are noted in the luteal phase, such as mood changes, sleep disturbance, feeling warmer. And it makes sense, I think, when we go back to the science. And then as GPs, how can we kind of support this? So I generally talk about the few days after menstruation. Generally, we feel a bit more well, we have more energy, and suddenly women smile. So a lot to cover, how can we do it? I tend to use the Green Climacteric Scale. You can find it on the Jean Hale's website. I've adapted it to talk about whether women experience a premenstrual exacerbation. This can help prioritize for them and for me, and also validate that their symptoms may be hormonal in nature. We've all heard women coming in saying, I'm crazy, no one told me this was happening. And actually, it's pretty common. Once again, looking at why. So there's a term called reproductive depression. And often when I see women with a really bothersome perimenopause or menopause, we go back and they've had postnatal depression, and I've started calling it hormonal mood challenges, because a lot of the time we haven't presented throughout our life. So for me, this really demonstrates that hormonal changes affect mood. And why? Well, there's lots of estrogen receptors in the brain and different kinds of estrogen receptors. So rising estrogen causes rise endorphins and serotonin. We know they make us feel good, so we can focus and concentrate better. So levels changing makes sense, we may feel different. Perimenopausal depression is an entity on itself. And I think we'll all remember women saying there's frequent changes and increases in irritability and anxiety, and they've never had this before. Professor Kulkarni is pretty inspiring, and she has developed a specific questionnaire for this. And also evidence, she's presented that symptoms of mood start 5 years prior to the physical, so the vasomotor symptoms and things of perimenopause. So statistics says motivation decreases at menopause. 40 to 60% of women have cognitive impairment at menopause, predominantly verbal nature. So it's understandable that women may feel that they've got Alzheimer's, but generally they haven't. I'm just going to have one slide about joint pain, because I think it's one of the most incredible symptoms that I hear have improved. Women who I started on HRT, as a disclaimer, generally in the menopause, and oh, my ankle fracture from 10 years ago suddenly feels better. Or the obese patient with their knee pain can suddenly feel better with walking. Genitourinary syndrome of the menopause, really undiagnosed and affects 25% of women in the pre-menopause. Unlike hot flushes and things where we adjust, the genital tissues do not adjust to low estrogen. Estrogen protects the tissues, and without it, they get smaller and we can get some inflammation. So on the slides, you can see urethral caruncle, and I definitely know as an obs and gynae, house officer and registrar, I referred this to urology on many a time, thinking there was urethral cancer, but it's actually signs of estrogen deficiency. So one of my big take-home messages would be, if anybody mentions bladder symptoms or pelvic pain or discomfort, consider genitourinary syndrome of the menopause. So how can we make it easy, applicable? Well, we moisturize our face, moisturize our vagina. The gold standard is hormonal creams, but actually for a lot of women, hormonal options aren't needed to a certain extent, and vaginal moisturizers are longer lasting than lubricants. It generally takes 3 months to work, so it is about persevering. And then as GPs, we're good at diagnosing dermatitis and eczema. Well, long-term disruption of the skin can be associated with dermatitis, and my go-to is mometasone ointment. So I'm just going to focus on hormone therapy because I think that's one of the areas that I know I had to learn about to feel comfortable prescribing it. So gold standard current medical management of menopause that's the safest in New Zealand is transdermal estrogen. So an estrogen patch known as estradiol or Clemera, and progesterone. So progesterone is a body-identical micronized progesterone that has just become funded as of the beginning of December. So how do we prescribe it? So once again, I get my diagram out. What do we want to do in the perimenopause? Well, even though levels are surging, they are lower overall. So we want to provide a buffer, but we know we cannot override the changing levels. So we have to support them. So if they're still bleeding, we need to go with a cyclical approach. So we need to do estrogen continually and then progesterone supporting our natural progesterone to stabilize the endometrium. I find these diagrams quite helpful. So we've got continual estrogen and cyclical progesterone. If there's increased heavy menstrual bleeding or irregular bleeding, then we can increase the duration of the progesterone and also the dose taken. This is also really helpful with busy routines where you can't remember what is day 14 and when my cycle's changing. But understanding that you're not going to stop your period with this progesterone, but you're going to support it, helps management. If a Mirena is in situ, then some people still find sleep and mood improvement with oral progesterone. So why use HRT? Well, I think I've hopefully kind of given you food for thought that actually hormones can impact mood. And the NICE guidelines do say that HRT is the most effective treatment for mood disturbance in the perimenopause. Hormone replacement therapy decreases the risk of many conditions when started within 10 years of menopause. And interestingly, improvements in well-being are seen in HRT with COVID and long COVID, and worsening perimenopause in women. But we're scared of HRT based on what happened in the past. The WHI study was prematurely released in 2002, and it said there's an increased risk of invasive breast cancer, blood clots, heart attack, and stroke. So we all want to do no harm, so that's going to instill kind of concern in us prescribing it. And for our women, it's also going to mean their friends question why they're on that approach. So there are criticisms of the women of the WHI study. The average age of women was 63. They'd have had potentially 10 years of lower estrogen causing atherosclerotic plaque increased weight as well. And it was a different kind of HRT. So I'm not saying that HRT is for everyone, but often it is safe. We need to consider the contraindications and do a risk assessment like we do for other medications. And putting it into context, what are our individuals' fears? What are they worried about? For example, breast cancer is a common concern. Well, if you combined HRT has a lower risk of breast cancer compared to being obese. And there are lots of evidence that does show starting HRT within 10 years of the menopause decreases cardiovascular risk. I'm obviously aware that the studies previously, albeit interpreted slightly differently, weren't so convincing, but I definitely think it's something that we can discuss with our patients safely. So whenever I'm prescribing HRT or seeing anyone in kind of late 30s or 40s, I'm considering the differentials alongside what the hormonal impact can be. I'm looking at the cardiovascular risk, lifestyle, and doing shared decision making. And I'm also talking about topical estrogen. A last fact for you. So low-dose antidepressant medication taken in the luteal phase for PMS can improve symptoms within 4 hours. Often women are really surprised, and this is really validating, that they're not clinically depressed, which is what women fear I've just made this kind of like resource sheet that I give to some patients, and there's some kind of good resources. So yeah, in 15 minutes, ask for top symptoms, validate, stick to your concerns as well, make sure you rule out the red flags, and ask to come back. And I did a study about 18 months ago on prolapse and incontinence, and one of the stats was that the best thing is being listened to, and I think we can do that when seeing women, even though it's a challenge in 15 minutes. So I probably went over, sorry, thank you.